My name is Gustavo Bedoya, and I will be presenting a case of infective endocarditis with paravalvular abscess caused by Staphylococcus lugdunensis. Staphylococcus lugdunensis is a coagulase-negative staphylococcus that makes up part of the normal human skin flora and is a rare but highly aggressive cause of infective endocarditis. It has a similar degree of pathogenicity as Staphylococcus aureus. However, its low prevalence carries the risk of being overlooked. Infective endocarditis caused by Staphylococcus has an ominous prognosis due to its association with serious complications, particularly paravalvular abscess formation. An 81-year-old male with a medical history of coronary artery bypass graft, bioprosthetic aortic valve replacement, and bladder cancer who presented to the emergency department after being found nearly unconscious inside his vehicle. Upon arrival, he was found to be hypotensive, tachycardic, and was complaining of severe back pain. The patient was stabilized, and upon further questioning, he stated that he had low back pain for the past 2 weeks and developed chills with generalized joint pain just 2 days prior. Physical exam revealed a grade 3 out of 6 systolic ejection murmur radiating to his carotids. Diagnostic studies showed neutrophilic leukocytosis, elevated C-reactive protein, and significant conduction abnormalities on EKG. MRI of his lumbar spine revealed L4, L5 lumbar discitis, osteomyelitis, and epidural abscess. The following day, Staphylococcus lugdunensis was identified by blood culture. After an inconclusive result on transthoracic echocardiogram, transesophageal echocardiography demonstrated thickened aortic valve leaflets and a paravalvular abscess seen in Figure 1. That same day, while pending transfer to a cardiothoracic surgery center, he developed sudden onset aphasia, left-sided facial droop, and a right lower extremity weakness. CT brain showed near occlusion of the left middle cerebral artery, and the patient underwent emergent mechanical thrombectomy. Acute left leg ischemia complicated his clinical course further, where he went for left femoral embolectomy. After the patient was stabilized, he was transferred to an advanced cardiovascular surgery center. Infective endocarditis caused by Staphylococcus is rare, and few cases have been documented up to date. Studies have reported Staphylococcus commonly results in complications such as paravalvular abscess, cardiac conduction abnormalities, and thromboembolic disease. Our patient developed most complications. However, he differs in that he had a bioprosthetic valve, and studies showed that Staphylococcus species, including Staphylococcus, affect native valves with higher frequency. Additionally, cases have shown that patients with history of operations below the waist later develop infective endocarditis with Staphylococcus, and interestingly, our patient reported a history of neobladder reconstruction. Unlike other coagulase-negative staph, Staphylococcus lugdunensis should not be presumed to be a contaminant, and keen investigation for possible infective endocarditis is warranted. Infective endocarditis complicated by paravalvular abscess requires prompt treatment, and cardiovascular surgery should not be delayed.